is applied in the popliteal fossa, which in the presence of significant intraspinal nerve root compression will cause the reproduction of pain in the sciatic distribution. Well leg raising test or crossed reference sign. In the presence of a large disc protrusion or a space-occupying lesion, performing the straight leg raising test on the uninvolved side may produce pain in the sciatic distribution on the patient's other or symptomatic side. Hence the name well leg raising test or crossed reference sign. Sitting straight leg raising test. The straight leg raising test can be performed in a sitting position. It is best to have the patient sit against a wall in order to prevent the patient from leaning backwards to compensate for increased tension on the nerve root. Reproduction of pain in the sciatic distribution would be considered a positive finding. Femoral stretch test. With the patient lying prone, the knee is slightly flexed and the hip is passively extended by the examiner. Pain felt in the anterior thigh is indicative of increased tension in one of the roots comprising the femoral nerve, L2, 3, or 4. Remember that the patient's response to these tests is subjective, and it is wise to do all of the tests in order to confirm the response. Note that the tests merely indicate that nerve root tension is present, but do not localize the lesion any more precisely than either being of sciatic or femoral root origin. Sensory examination. The following points must be noted on sensory examination. Explain to the patient precisely what is going to happen, and during testing the patient should have the eyes closed. It is essential that each dermatome be examined separately and compared to its opposite. The patient's response to pinprick,
sharp,
blunt touch,
dull,
and light touch
yes,
must be examined, and further examination of temperature,
hot, cold,
two-point discrimination,
two,
vibration,
yes,
proprioception,
up, down,
and deep pain may be indicated.
yes,
If any deficiencies of the sensory examination are noted, record these on a diagrammatic chart showing the dermatome distribution and depict the localization and area involved so that this can be used for future comparisons. Motor examination. Essential points in the examination of the motor system include the following. Examine each specific muscle or group of muscles when the individual muscle function cannot be isolated. Always palpate the individual tendon or muscle if possible. Record the strength of the muscle or group of muscles being tested on the 0 to 5 rating scale. Always compare one side to the counterpart on the other extremity. Examine all of the foot and ankle dorsiflexors with the knee in a bent position, such as the sitting position. Examining in a position with the limb extended may produce sciatic pain, which will interfere with the results of the examination. In testing for muscle strength, unless an obvious weakness has been noted previously during the examination, It is best to test against full resistance or grade 5 power, then work backwards if weakness is detected. Foot and ankle extensors. Extensor hallucis longus, L5, deep perineal nerve. The patient is instructed to extend the big toe, and the examiner then attempts to flex the big toe. It is necessary to apply pressure distal to the interphalangeal joint in order to test only the extensor hallucis longus and not the extensor hallucis brevis. Extensor digitorum longus and extensor digitorum brevis, L5, deep perineal nerve. Instruct the patient to extend the small toes and apply pressure to the dorsal aspect. The examiner should not be able to plantar flex the toes under normal circumstances. Tibialis anterior, L4, deep perineal nerve. The patient is asked to invert and dorsiflex the foot. Obviously, the patient cannot be expected to understand these instructions, and by placement of the examiner's finger in the proper position and asking the patient to touch the finger with the big toe, the ideal position can be achieved. Pressure is then applied to the medial border of the foot, attempting to plantar flex and evert the foot, and with the other hand, the tendon of the tibialis anterior can be palpated by the examiner. Foot and ankle plantar flexors. Flexor hallucis longus, S1, tibial nerve. The patient is asked to plantar flex the big toe, and the examiner attempts to dorsiflex the toe. Note again that the examiner's resistance is applied distal to the interphalangeal joint. Flexor digitorum longus, S1, tibial nerve. Instruct the patient to plantar flex the lesser toes and attempt to extend the lesser toes, which should not be possible in the normal patient. Tibialis posterior, L5, tibial nerve. The patient is instructed to plantar flex and invert the foot. While applying resistance to this motion, the tibialis posterior tendon can be palpated behind the medial malleolus. Peroneus longus and brevis, S1, superficial perineal nerve. The foot is brought into a position of plantar flexion and eversion by asking the patient to touch the examiner's finger held in the appropriate position. Pressure applied to the lateral border, attempting to invert and dorsiflex the foot, will allow the muscle function of the peroneus longus and brevis to be graded. Gastrocnemius soleus complex, S1, S2, tibial nerve. Because the gastrocnemius soleus muscle is the strongest in the body, significant weakness has to occur before it can be detected by the examiner applying resistance. The gastrocnemius soleus should therefore be tested actively, as in toe walking and in the ability to do 10 toe stands. During toe walking, look for partial sinking and inversion of the heel, or during toe stands, look for decreased speed of performance as well as fatigability. During toe stands, it is essential that the knee be kept straight. Knee extensors. Quadriceps, L2, 3, 4, femoral nerve. The quadriceps muscle must be tested as a group. The patient is in the sitting position and instructed to extend the knee. One hand of the examiner stabilizes the thigh and palpates the quadriceps contraction, while resistance is applied by pressure just above the ankle joint to the lower extremity. Hip flexors. Iliopsoas, L1, 2, 3, femoral nerve. With the patient sitting, the hip is further flexed against the examiner's resisting hand. Obviously, it is not possible to palpate the iliopsoas muscle or tendon. Hip adductors, L2, 3, 4, obturator nerve. primary adductor longus, secondary adductor brevis, adductor magnus, pectineus, gracilis. With the patient lying in the supine position, the leg is abducted, and by stabilizing the pelvis with the forearm, the patient is instructed to bring the leg towards the midline. Resistance is offered by the examiner by pressing against the medial aspect of the lower leg. Hip abductors, L5, superior gluteal nerve, gluteus medius, gluteus minimus. The patient lies on the side and the uppermost leg is abducted. Obviously, if the patient can do this, at least a grade 3 muscle power is present. Resistance is then applied to the leg by the examiner and the abductor region is palpated. Care must be taken to assure that the patient's hip does not externally rotate or flex to avoid any contribution by hip flexors or the tensor fascia respectively. Knee flexors. Hamstrings. Medial L4-5, lateral S1-2, sciatic nerve. The patient is instructed to flex the knee to approximately 60 degrees while lying in the prone position. The examiner offers resistance by applying pressure behind the ankle and with the other hand stabilizes the thigh and palpates the hamstring muscles. Hip extensors. Gluteus maximus S1, inferior gluteal nerve. With the patient still in the prone position and the knee flexed to 90 degrees to eliminate any contribution to hip extension by the hamstrings, the patient is then asked to extend the hip and resistance is applied on the back of the thigh while the other hand palpates the region of the gluteus maximus or buttock. Abdominals. T5 to T10 above umbilicus, T11 to L1 below umbilicus. The patient lies in the supine position and is asked to perform a partial sit-up. The abdominal muscle is palpated to assess tone. If all four quadrants of abdominal musculature are normally contracting, the umbilicus will remain stationary, whereas weakness of one or more of the quadrants will be manifest by movement of the umbilicus towards the stronger quadrant or quadrants. This is known as a positive beaver sign. Although some examiners may test all the muscles of a single root, for example, L5, extensor hallucis longus, extensor digitorum longus, tibialis posterior, and gluteus medius, I prefer to proceed up the extremity in a systematic fashion as has been described during this examination. Reflexes. There are three types of reflexes that the examiner attempts to elicit during the neurological examination. This is really the only part of the neurological examination which is objective and does not rely directly on patient cooperation and response. Deep tendon reflexes. A direct anatomical arc is involved in the deep tendon or stretch reflex. The essential elements are the stretch receptor, afferent nerve fiber, a synapse in the spinal cord, an efferent nerve fiber, and a muscle end organ. The deep tendon reflexes can be modulated but not directly controlled by impulses from the brain. The absence of a deep tendon reflex would suggest interruption of the reflex arc. Nerve root pressure insufficient to completely disrupt the reflex arc will result in a decreased or hyporeflexic state. Absence of cerebral or upper motor neuron regulatory control will eventually result in a